All right, acute compartment syndrome and crush injuries. All right, ACS, acute compartment syndrome, it's a medical emergency that's typically going to arise after a traumatic injury. This occurs when increased pressure within a closed muscle compartment comprises circulation and nerve function, potentially leading to permanent damage if not properly treated. All right, so it's going to follow a traumatic injury. That muscle's compromised for long periods, and that leads to ischemia and acidosis. Okay. In the field, we're most likely going to see this occur with crush injuries. You can see it from like tight casts that are left on the patient for a long period of time, burns, things like that. But for us, most commonly, it's going to be some sort of crush injury. So let's picture a patient that is trapped underneath a large light pole, something like that. All right, felt both their legs. It's been there for quite some time. The longer it's there, the more likely we're to develop ACS. Okay, so that prolonged continuous pressure on large muscles like the legs or arms is going to result in muscle damage and cell death. The injury is associated with release of potassium and lactic acid. All right, so our treatment has to be directed at replacing fluids. We want to establish high urine flow rates. That's going to flush out our kidneys. We've got to protect the kidneys and hopefully reverse metabolic acidosis. All right. The injury duration and the amount of muscle involvement are significant determinants of our outcome for the patient. So our main treatment with this, want to get normal saline, 20 mLs of key, flush out those kidneys, hopefully reverse some of that acidosis. Bicarbonate calcium chloride, 50 milliequivalents of bicarb, 1 gram calcium chloride. That's going to push the potassium back in to the cell. Right now we have excess amounts of potassium in the bloodstream, becoming acidotic. We want to reverse that by pushing potassium back into the cell. Now, for some reason, we only have one line. Remember, calcium is actually going to push that potassium back into the cell quicker than bicarb. So if we have to, we go calcium first, then get bicarb. Hopefully we can get 2 lines. Regardless, we want to administer all of these drugs prior to removal of that object. So if we got the light pole on the legs that are stuck, we want to make sure we do all this treatment prior. Because as soon as we move that, that blood flow is going to be reestablished. And from there, all of that acidity, all that potassium, we're moving back toward the heart, the rest of the body, all of our vital organs. We don't want that. We want to preemptively treat this patient with these drugs. The last one we can give is albuterol nebulized 2.5 milligrams. All right. So our main goal, increase kidney filtration, push potassium back into the cell. Now, most traumatic patients, we're not super concerned with the 12 lead. It's going to be something way later in our assessment. For this, however, it's very good to get a 12 lead quickly, especially if we are waiting on resources. Not going to be able to move that object quickly. Let's get a 12 lead. Because the 12 lead in these patients is going to be very similar to what you might see in a renal patient. So as it progresses, the start will be a tall peak T wave, something like this. Continued progression, you're going to have a loss of that P wave. QRS might be a little wider. Now we're going to have the T wave might be a little wider. Now we're going to have the widening of our QRS and T wave still peaked up here. And from there, it can lead to VTAC. So these are pretty much the same drugs we would give for a renal patient that's presenting like that, okay? So finally, again, we can give that albuterol after the administration of normal saline, sodium bicarb, and calcium chloride. All right, we give the albuterol because it's a beta-2 adrenergic agonist, and that's going to stimulate potassium moving back into the cell. It's the intracellular shift of the potassium ions back into the cell. All right, so it's great for crush injuries and ACS. Bicarb, it's going to act as a systemic alkalizing agent. It buffers with the excess hydrogen ions, raises our blood pH, right? Because we're becoming acidic, below 7.35, we want to raise that back up. Calcium, again, it's going to move that potassium back into the cell where we want it. And the saline is going to be flushing out our kidneys. All this is hopefully going to relieve that acidosis. Again, this needs to occur prior to you moving whatever object is on. So when we talk about metabolic acidosis, respiratory compensation, right? Crush injury, systemic crush syndrome through traumatic rhabdomyolysis is probably going to occur, right? Damaged muscles are going to release that lactic acid, potassium, myoglobin, and other toxins into circulation. Metabolic acidosis occurs due to a lactic acid accumulation and impaired clearance via the kidneys. So we have a myoglobin-induced renal injury though. Our respiratory system is going to want to compromise. Okay, so that normal response for metabolic acidosis is hyperventilation. Right, respiratory compensation is going to hopefully lower that CO, normalize the pH. At this point, though, we might have metabolic and respiratory acidosis. This is when they can coexist. It's not very often that they do. But respiratory acidosis arises only if our ventilatory function is compromised. So, if we're having any impedance of our ability to get full tidal volume in the lungs, our respirations are not adequate, then we might have an acidic state in both aspects, right? But otherwise, that metabolic acidosis is going to trigger the respiratory compensation and not further respiratory acidosis. And that's going to occur until the patient decompensates and we will slow our breathing. Eventually, that's going to lead to death.